Welcome to this complete masterclass on the types of IV solutions and fluids. We will cover crystalloids versus colloids, hypotonic, isotonic, and hypertonic solutions, as well as nursing care plans. Let's start with some basic concepts. The solute refers to particles like sodium or glucose dissolved in water. The solvent is the fluid part, which is water. The solution is the combination of the solute and the solvent, such as normal saline. Osmosis is the movement of water from an area of lower solute concentration to higher solute concentration through a semi-permeable membrane. The simple rule is that water follows salt or solute. Osmolarity is the concentration per liter of solution used for labeling IV fluids. Osmolality is the concentration per kilogram of water used for body fluids. Normal serum osmolality is 275 to 295 milliosmoles per kilogram. Tonicity describes the effect on cells. Isotonic solutions cause no fluid shift, and the cell stays the same size. Hypotonic solutions cause fluid to move into the cell, making it swell. Hypertonic solutions pull fluid out of the cell, making it shrink. A trick to remember is hypo like hippo, because the cell swells. IV fluids are classified into crystalloids and colloids. Crystalloids have small molecules, used for maintenance and rehydration. Examples include normal saline and Ringer's lactate. Colloids have large molecules that stay in the blood vessels, used for volume expansion. Examples include albumin and dextran. Here is a quick question. Which IV fluid is the only one compatible with a blood transfusion? The answer is normal saline, or 0.9% sodium chloride. Isotonic solutions have an osmolarity similar to plasma, between 250 and 375 milliosmoles per liter. They expand the intravascular compartment without shifting fluid into cells. Indications include hypovolemia, hypotension, and use during surgery. 0.9% normal saline is composed of sodium and chloride in water. Key uses include shock resuscitation, blood transfusion compatibility, hyponatremia treatment, and metabolic alkalosis. Ringer's lactate or Hartmann's solution contains sodium, potassium, calcium, chloride, and lactate. It is physiologically similar to human plasma. Key uses are for burns, diarrhea/dehydration, and surgery. Nursing alerts for Ringer's lactate include contraindications for kidney failure due to the potassium content, liver failure because of the risk of lactic acidosis, and a pH above 7.5 due to the lactate converting to bicarbonate. Comparing normal saline and Ringer's lactate, normal saline contains only sodium and chloride, while Ringer's lactate contains sodium, potassium, calcium, chloride, and lactate. Normal saline is best for blood transfusions, but carries a risk of hyperchloremic acidosis. Ringer's lactate is best for burns, but carries a risk of hyperkalemia and renal failure. Dextrose 5% in water, or D5W, is known as the chameleon fluid. It is isotonic in the bag, but the dextrose is quickly metabolized in the body, leaving only free water. This causes the solution to become hypotonic in the body. It is used for hypernatremia and provides calories, but should be avoided in head injuries. The fluid of choice for burn patients in the first 24 hours is Ringer's lactate. This is because its composition closely mimics plasma lost in burns, and lactate helps buffer metabolic acidosis. Ringer's lactate contains sodium, potassium, chloride, and calcium, but not magnesium. Hypotonic solutions have an osmolarity less than 250 milliosmoles per liter. They cause fluid to shift out of blood vessels and into cells, causing cells to swell. Examples include 0.45% normal saline and 2.5% dextrose. Hypotonic fluids are indicated for cellular dehydration, used after initial stabilization in diabetic ketoacidosis, and for hypernatremia to dilute high blood sodium. Hypotonic fluids are an absolute contraindication in head injuries or increased intracranial pressure. They move water into brain cells, increasing cerebral edema and potentially causing herniation. Why shouldn't you give 0.45% normal saline to a patient with a stroke? Because it causes brain swelling or cerebral edema. A patient with increased intracranial pressure should not receive 0.45% sodium chloride because it is a hypotonic fluid. Hypertonic solutions have an osmolarity greater than 375 milliosmoles per liter. They pull fluid out of cells and into the blood vessels, causing cells to shrink and blood volume to expand. Examples include 3% sodium chloride and dextrose, 10% in water. Hypertonic fluids are indicated for severe hyponatremia and cerebral edema. They should be administered slowly, possibly via a central line, due to the high risk of fluid overload. Mannitol is an osmotic diuretic that pulls large amounts of water with it, making its golden indication decreasing intracranial pressure. Nursing precautions include warming the bottle if crystals form and always using an IV filter. If crystals are observed in a mannitol bottle, the appropriate action is to warm the bottle in warm water to dissolve them. The IV fluid indicated for a patient with severe hyponatremia and neurological symptoms is 3% sodium chloride, which is a hypertonic fluid. Colloids, or volume expanders, contain large protein molecules that cannot leave the vascular space. They increase oncotic pressure, pulling fluid from tissues into vessels. Examples include albumin and dextrin. Crystalloids are cheaper and better for maintenance, while colloids are more expensive and better for volume expansion in severe shock. Crystalloids can pass through membranes, but colloids cannot. Phlebitis is inflammation of the vein, with signs including redness, warmth, pain, and a palpable cord. The action is to stop the infusion, remove the cannula, and apply a warm compress. Infiltration is fluid leaking into the surrounding tissue. Signs are coolness, swelling, and pallor. The nursing action is to stop the infusion, remove the cannula, elevate the limb, and generally apply a cold compress. If an IV site is cool, swollen, and pale, this indicates infiltration. Fluid overload, or hypervolemia, is a risk for patients with heart or kidney failure. Signs include dyspnea, crackles in the lungs, and jugular vein distension. The action is to slow the IV rate, position the patient in high Fowlers, and administer diuretics. The visual infusion phlebitis, or VIP scale, is used to grade the severity of phlebitis, ranging from 0 for no signs to 5 for advanced thrombophlebitis. IV drop calculation is crucial. Drops per minute equals volume in milliliters times the drop factor, divided by the time in minutes. Macro drip factors are typically 15 or 20 drops per milliliter, while micro drip is 60 drops per milliliter. For an order of 1,000 milliliters of normal saline over 8 hours with a drop factor of 15, the drops per minute calculation results in 31 drops per minute. Monitoring IV therapy involves hourly assessments of the rate, site condition, and tubing. Always document the site condition and volume infused every shift. In a burn patient scenario with massive fluid shift, the fluid of choice is Ringer's lactate according to the Parkland formula, to replace volume and electrolytes. Normal saline is avoided in large volumes due to the risk of hyperchloremic acidosis. For a patient with a traumatic brain injury and raised ICP, hypotonic fluids like D5W must be avoided. Normal saline is used to maintain blood pressure, and treatment includes mannitol, or 3% saline to pull water out of the swollen brain cells. A care plan for fluid volume deficit includes nursing diagnoses, goals, and interventions, focusing on monitoring for signs of dehydration, increasing fluid intake, and administering IV fluids as ordered. A care plan for fluid volume excess involves diagnoses, goals, and interventions to address signs of fluid overload, restricting sodium and fluid intake, monitoring vital signs, and administering diuretics. The golden rule for potassium is never to give it via IV push, as it causes immediate cardiac arrest. Always dilute and infuse slowly, with a maximum rate of 10 to 20 milliequivalents per hour. Always check urine output before adding potassium. Before administering IV potassium, the nurse must assess the patient's urine output to ensure the kidneys can excrete the excess potassium, preventing hyperkalemia. This video provided a summary on fluid selection, covering the different types of IV fluids, their uses, and nursing considerations for safe administration. Remember these high-yield revision points. RL's lactate becomes bicarbonate, D5W is hypotonic in the body, infiltration sites are cool, phlebitis sites are warm, mannitol requires a filter needle, and daily weight is the best indicator of fluid status. For further reading, please consult standard nursing textbooks, such as Brunner and Sutterth's and Potter and Perry's, and the Infusion Nursing Society standards.